Welcome everybody. It's great to see you all here. I'm David Sandman. I'm the Senior Vice President here at the Foundation. Happy to welcome so many of you back, or some of you for the first time, particularly to welcome Anna English, who came all the way from Colorado to be with us today. Anna is the CEO of CIVIC, the Center for Improving Value in Healthcare, which I guess among its foremost responsibilities is to run the APCD for the state of Colorado, and that was really one of many reasons that we hoped that she would come and visit us. There's probably about 30 states or so who are at some phase of either having or exploring or dreaming about an APCD, and New York's kind of in the middle of that pack. But there's really only a very small number of states who have a truly fully up and running, fully functional APCD that's doing it all, producing reports, and CIVIC is certainly among the leaders of that crowd. So New York, we have our enabling statute. It was passed more than 4 years ago. It's a long, slow process. So we're trying to move that forward, and Anna has a lot of important lessons to share with us on how they did it, how to do it the right way, things they might have done differently if they had that opportunity. That's really the first thing that impressed us, as New York kind of steps on the gas yet again to build our APCD out. But I think what really impressed us was the way they're using it. It's not just this massive database. We called this session leveraging big data to improve value in healthcare, because that's exactly what they're doing. They have a consumer-facing price transparency tool. It's probably the best one that I personally have yet to see. We're amazed and impressed by that and want to hear about it. They're using it to support bundled payments and payment reform efforts in the state. So, not just having the APCD, but actually realizing its potential is what impressed us so much. And so we're happy that you accepted our invitation. Anna has been the CEO for 8 months or so now. And prior to joining CIVIC, she was part of the executive management team with the AMA, where she ran a lot of their business enterprises as well. Prior to that, she was with a company called the Assist Group, which worked on large medical claims resolution. Also spent time with Optum earlier in her career, and even started out with some insurers. So brings many, many years of experience to her current job. So it's going to be our usual kind of informal format for these events. Anna's going to share some materials with us, and we're going to save a lot of our time for discussion and Q&A. So thank you all for being here, and it's all you.
Great. Well, thank you. Can all of you see and hear me all right if I just sit and keep this informal? If I need to stand, I'll do so. Based on that introduction, yes, I'm actually 110 years old, and I do color my hair, but I've been in healthcare, since the beginning, and I have to say I'm very passionate about healthcare, and moving back to Colorado from having spent the previous 4 years in Chicago at the American Medical Association. There's nothing like Colorado. I'm very happy to be back there. And I think the key is that within Colorado in and of itself, one thing I've always supported on a national basis and had within my area in Colorado, and have seen all the great things that they've been doing within Colorado. But when you're at the ground level, Colorado is doing a lot of things that are right. And from a healthcare perspective, a lot of things that are a work in process. It's pretty amazing to really see all of the activities that are occurring there. So anyway, with that, let me just make sure I'm hitting the right button. So just want to start out with that, okay, the Colorado All-Payer Claims Database, it's functional, and it's available. And the question really for me, as well as for our team and everybody that we support, is, how do we collectively, make the best of it, really to make the best use of it to have a positive effect on healthcare and really help to make changes and good changes occur? The answer for us is by making it accessible. And we've got in the small print, as long as it's appropriate, it's within HIPAA and security and high-tech guidelines. And the other thing is we also got antitrust that's in there as well. And I think the one message, and your name, the title that you're using is all payer data. The reality is that it is more, to really affect change within healthcare, it is more than just claims, but claims is a great place to start out. And we all have to start somewhere, and I think that's some of the message in general. And the key is that having data in and of itself is meaningless. What you do with it is the true value. And I think we're right now really on that cusp of being able to show what the value of all of this great information that we have and what can be done with it. And I think that's really the movement across the whole country, not just within Colorado as well. So let me just give a little bit of information regarding Civic. We're a nonprofit, nonpartisan organization. We were founded out of recommendation from the Blue Ribbon Commission on Healthcare Reform. That was in 2008. And our focus is the AAA mission, better health, better care, lower costs for all of Coloradans. That's very big. Triple aim is about as broad as you can get. And the key for us is, so what does it mean? What's the space that we can play to really help make a difference? What we do, real simply, we drive, deliver, buy value in healthcare. Again, very big, very broad messaging, but truly, what we're about is helping to understand and really pinpoint what is that core bit of information that will help identify where we can make changes. We really help to deliver that information. And again, this is all about the exchange of services. It's all about buying healthcare. And whether you're a payer, whether you're a consumer, whether you're another provider group, again, all of it is about the exchange of services and what money is exchanged for that value. How do we do it? Specifically, we talk about data. And I don't think we really need to explain so much, regarding, what is it that, right now we're talking about the all-payer claims database. Our bigger picture regarding data is beyond claims. It's in the socioeconomic factors and information and indicators. It includes vital statistics. We do a lot right now as far as the death registries, the birth registries. We do a lot of analytics regarding immunizations as well, and clinical. The key right now are what are those use cases to really merge together claims and clinical information to have it be meaningful. Consulting. You think about consulting and you're out there selling your services to help provide insights and help other organizations. Consulting really ends up being a part of our every single day work. We have customers come in and individuals and say, I have a need. This is what I think you need. This is what I think I want in order to meet this objective. And the reality is we really have to work with them to understand what is it they're trying to get to, what sort of information and or analytics will help them get to that end result. And it's a work in process. We have so many individuals and groups that are coming to us and say, we need the entire database. Well, first off, you can't have it. And second of all, what is it that you're truly looking forward to get? Because in some cases, in the first year that Civic was actually not giving away, but basically providing data, they asked for these databases or this bits of information, and then they didn't have the means to actually do it. So we've actually had to come back and provide more analytical services and expand those types of services in order to really meet the needs. And then connecting. The key is through all of this work that's being done with the data and then understanding what the needs are and what sort of analytics and information is needed. Once you have it, it's not in and of itself, you got to do something with it. So we help bring together partners, whether it's a payer, a provider group, to really pilot and test, whether it's integrated delivery systems, whether it's care transitions, whether it's testing out a new payment reform and or a new particular payment model. So we help bring together those groups in a non-confrontational manner and really look at, okay, how can we pilot and see if this is the best way to go and make it work. Within 30 days, one of the amazing parts within, and David and I were talking about this earlier, one of the amazing parts within Colorado is that there are so many nonprofits out there and other organizations. And my first really 60 days was about meeting every single day, yet another nonprofit group, association, meeting with the payers and the providers, et cetera. And we have a lot of groups within Colorado that are very passionate about their particular focus group. But the one thing that came and walked away with fairly quickly is really understanding is what's the key to civic success. And the reality is that foundational to everything we do is data and analytics. It's not about convening. It's not about talking about the next new payment reform. It's about ensuring that we have got a very hardcore foundational data and analytics, and that we have a system put in place that we are able to identify and work together with our constituents of working together to identify opportunities to affect care and healthcare. And one of the things that we've said is, you know, some of the reports that go out, I call it the fluff reports. So you get an analysis and you say, oh, that's nice, and you stick it on the shelf, never to be looked at again, because it doesn't necessarily give you information that's actionable. And so what we really try to strive for from a culture perspective is we say no fluff here. So we really have to go into those analytics, understand what the purpose is, and make sure what we're producing and or providing and or helping to work through is going to be actionable at some point. Okay, the key is what do we do with that data and analytics? Very important and central is public awareness. It's not just the consumer side, but it's really raising the awareness in general about what can be done with the information to help affect change. And then we have very specific programs around payment reform as well as healthcare delivery. Care transitions for us is a big area that we work with. We're doing some great analyses in palliative care from a payment perspective as well as from a specific models. And we're really excited about what we're doing from that regard. And then again, the key is really what are we doing through these programs, foundational from, again, data and analytics, of really affecting change. And it's more than just managing the APCD. The wrapper around everything is our sustainability, or basically our business model. What is the value that we're providing to all of the various stakeholders? We have to be Switzerland. We are in the middle. And we support payers, we support hospitals, we support ancillary providers, physician groups, practitioners, research and academics, the state governments, you know, so every single constituent or stakeholder within healthcare, we have to make sure that we're meeting their particular needs. And that's, from a business model perspective, that's really the driver, and ensuring that everything that we produce fits within our overall mission as well, which is in support of the AAA. Again, very, very big from that regard. Just real simply, what is covered within our APCD right now? We've got Medicaid, we've got Medicare fee-for-service, as well as Medicare Advantage, and we've got the 20 largest commercial payers. Anybody that's less than 1,000 in total membership is not required to participate. We've got actually closer to just over 335 million medical and pharmacy claims. We're bringing dental in this year. We've got 3.5 million unique lives. Not very big when you look at New York, but from a Colorado perspective, it represents around 65% of the insured population. We are right now in the process of bringing it self-funded. That was a lesson learned that was excluded from the regulations initially, had nothing to do with the legislation. It was how the regulations were written. But we'll be bringing in self-insured. Cross your fingers as long as the hearings go well in March and April. And so we'll be well over 90% of the Colorado population. So the only thing that will be missing is the uninsured. And there's discussions regarding how can we bring in self-pay information as well. The all-payer claims database, again, as we talked about, was a state mandate. It came about in 2010 legislation as a result of the Blue Ribbon Council, the commission that was put in place in 2008. Civic was named the administrator by the state agency, is who we report to, one of the great reports we have to provide on an annual basis. The claims are collected from all public and private payers. Our first aggregated public reports were published at the end of 2012. We received no general state funds, zero. We are currently grant funded and with targeted sustainability by 2016 on through 2017, and we are on track to meet those goals and objectives. Okay. Talk a little bit regarding our stakeholder engagement and governance. We do a no surprise approach. With everything that we produce on a public basis, we go through preview periods and make sure that the affected stakeholders and their corresponding associations are engaged with us. And the one thing I have to say Colorado did, and also in Civic when they first structured themselves, was our governance model. We have a framework, not only as it relates to managing HIPAA security and antitrust guidelines and privacy, but it's regarding how do we manage that. Part of the legislature was an APCD advisory committee, so that is a mandate. It has broad representation, and those positions are named by the governor's office, and we ensure that we have an active participation. This group is extremely active in the management of not only the APCD, but in particular as it relates to civic. We also have a data and transparency advisory committee. Again, multi-stakeholder. This is not mandated, but this is one that we appreciate, and again, it allows for us to get credibility in what we do and how we're going about doing it, as well as the communication. And then one very, very important aspect in committee is the data release review committee. So we have standards as it relates to PHI versus de-identified data sets. But this data release review committee is very engaged. They meet every single month. We will have special meetings that we'll do also via emails if we need to have a special timeline that needs to be quick. They evaluate every single PHI. They also we report to them on every single data release on a non-public basis, or on the de-identified data releases as well. And they are a very active participant in the approvals of how we're releasing the information. They will also sometimes act as a privacy board. So really, when you look at these three committees, it's very critical to who we are, the validity, the objectivity, as well as the manner in which we operate. The stakeholder groups, and you mentioned this earlier, we work on a daily basis very closely with every association that there is within Colorado, and there is a lot of them. These are just some of the main ones that we participate with. One of the items, as far as some of the issues and challenges, is that the state of Colorado, because the state of Colorado and the Department of Insurance did not have any sort of oversight regarding self-funded information, they opted to go ahead and leave it out of the regulation. You know, and it was fine for where they started and based on a lot of the different feedback, but it has become an issue that we are missing the self-funded. We have certain communities, because truly healthcare is local, so we go down to a lot of information and data at the very most minute level, and where you have a lot of self-funded information, it plays a role in the credibility of the data, where some communities have large number of self-funded employers, and you're really looking at a small representation. Even though we've got 65% of the population that's being represented, it does have an impact. So we believe this is extremely important for us. We do have certain Medicare restrictions. We are pegged. We are a qualified entity, but we also are a state agency, so we are able to work through a lot of the Medicare restrictions, but one in particular is that we're not able to report at the individual physician level. We are working through that with some of the changes that are being made. Hospital provider concerns. What's going to be done with the data? How is the data going to be reported? Is it truly going to be reflected of the critical nature of the particular patients that I have? And mine are much more complicated than anybody else. So we really have had to address this. So we do risk adjustment, we do those comparisons. We've really worked with the Colorado Hospital Association and some of the other entities regarding how do we present the data. They all preview it. They all get a chance to see it in advance and work with it. There's a lot of national competition. One of the things that I worked on with my team when I first came on board is really going through some strategic planning and looking at some, what is the situation that we're in. And the reality is anybody that can do what we're doing in any piece or partial component, they're our competitor. And we've really got to ensure from a total picture perspective that we're doing the highest amount of value, hence the name, but we're providing the highest amount of value to our constituent groups in Colorado, but also with what we're able to do and support on a national basis as well. Assessing the healthcare system needs to be more than just claims, but it's a great start. So again, I talked about vital statistics, social economic factors, clinical data, claims beyond just, we've got to look at all of health claims out there. We have a lot of people that are really excited about us getting dental in, but we're really not sure as to what we're going to do as far as the analyses, but we'll figure it out once we start getting the data rolling in this year. But the key is that we've got to broaden ourselves beyond claims, and that's part of our core strategies as well. Claims data can be messy, and you heard the statement, claims is dirty. And when you're rolling together 20 different payers, Medicare and Medicaid, all into a single database and trying to make sure that it's meaningful, well, some data comes in, fields are missing. Colorado has a Clean Claim Act, and also they're required to go ahead and pay claims within 10 business days if they go ahead and meet all of a certain number of requirements. Well, they leave off the rendering physician, and it's okay within Colorado. So again, we've really got to make sure that when we're merging that information together, it's meaningful. We have a provider index. Anybody that's been in the payer world knows that every single payer is always working on their provider directory and their provider database, because it's always ever changing. And so for us, multiply that times 20 and then add in Medicare and Medicaid, and it's really messy on trying to make sure we're pulling it together. So we work with Colorado Medical Society, the hospital associations, and all of the various other groups in order to ensure that that index, which is very large, is truly representative of what's actually happening. Lifetime and collecting processing, this is becoming a bigger and bigger issue for us, especially as we want to be looking at claims versus clinical. We receive claims that are already 45 to 60 days aged when we get it, because they have to be fully adjudicated and processed. And then there's that run out period. And then we go through a cycle, right now a quarterly cycle, of taking those monthly files that we receive, going through risk adjustment, cleansing, provider indexing. We use the Clarity tool to actually fill in some more of the provider fields to try to get this information as good as possible. And the reality is before we publish that information, it could be 6 months old. We're trying to work to say, okay, how can we get that how can we get that into a monthly processing? And we're actually working, with our data management group to really try to figure out what can be done. We're going to have to give up on some items in order to be able to speed up that monthly cycle. The reality is it's still going to be at least 60 days old, 60 to 90 days old, but it's better than what it is now. I do have to say, coming into the organization, this is a really good place to be when other states want to say we want to do and replicate what Colorado is doing. So Colorado is quasi-public-private. We are named as the administrator for the state, but we are a 501c3. We have a strong governance model that I talked about previously. We have a stakeholder transparency focus. We don't want any gotchas. So we want to make sure that the stakeholders, primarily the provider community, is fully aware in advance of what is going to be coming out and what our plans are. And as well as get their input before we finalize those plans. Public and non-public use. Non-public is primarily our business model, but again has significant value associated with it. And tied to that is our sustainability model. We have to be on our own 2 feet, basically. A focus on accessibility. This differentiates us significantly from other APCDs. We are about how do we make this information available, and that's using our privacy and security as a framework and not as a crutch, and that's very much a distinction. We talked about expanding data, and then for Colorado's APCD, we have this overarching requirement, must benefit Coloradans. We get a lot of requests throughout the entire nation, and it's very easy for them to provide some level of information, white paper, report, that can benefit Coloradans because they're basing their analyses and their work off of Colorado data. So the question now is, how does APCD support, am I going too fast or? No. Okay, great. Okay, so I'm going to keep going, and I'm going to be, the hook is going to be coming here soon, so I'm going to try to probably speed up. How do we support consumer engagement? So this is comedprice.org. Basically on this side of the screen, this is all about population information, both quality and cost information, in which you can look at. You can see the list that we have right now. When we roll out the new site in June, there will be a greater list of information that is basically occurring on this right hand of the screen. A big item for us is related to total cost of care by 3-digit zip code, by county, by hospital region area, whatever it may be. But basically all of this information can be extracted. It's used a lot by communities and also by researchers as well. The left side of the screen is really pertinent to consumers. It has named cost by facility. And we'll talk in a minute regarding how we're going to be rolling it out. But this side, the other side of the screen, or the left-hand side of the screen, really just rolled out this past summer, and we call it our soft launch. And we'll talk about the stuff that's going to be rolling out this year that we really want to get a lot more exposure on. I think the key here is that we don't just report data, we interpret it. So there's symbols, there's ranking, there's little bits of information that help make it more meaningful for the consumer. We provide the factors besides just the cost, and that's one of the requirements that we have. Part of it's self-imposed to the level that we're doing it, but it also gets a lot of validity to our with our stakeholders and credibility as well. We always pair cost with a quality indicator. Now the difficulty is truly finding a cost or quality indicator that's actually relevant to the cost indicator. But again, it's a starting point, and it's so we do put that firm in everything that we do. Communication, we really try to educate on the variation of the data and the information. The other thing too is we use plain English versus using the typical healthcare jargon that we all love, and with any new organization that we go to, you get handed an acronym book, of basically abbreviations, and I think that's the biggest challenge, is really getting out of the healthcare speak. We really try to say with these particular bits of information why it matters and why it should be important to you as a consumer. And then really, I think the key part is that recognizing that consumers really don't know that they have options. Healthcare is so complicated. So we really try to spell out as simply as possible. And the key is that they really don't want to necessarily sway from their provider's recommendations. But I think it's also important to note that when providers make recommendations, they don't necessarily know what the complexity of their friend that they may have been, they just know that they're a good doc, they like them. They don't know that they charge 5 times more than this other doc that happens to be a good practitioner as well, and someone that they would recommend just as likely. So the awareness is not necessarily just for the end consumer, it's also for the other providers that are out there as well. We've done a number of focus groups before this initial site went out. We're going to be doing several others actually starting in March, and we'll be incorporating those in probably with our December release of the site with updated data as well. What's really different about comedprice.org is simply, you state it with these 3 key items. We base it on actual pay, not billed charges. Prices include payments for the entire healthcare, and this came out of the focus group, and this was very important. You would think they'd want to know what their bill was going to be from Mercy Hospital. No, they know they're going to get a bill from all these different organizations. They're going to get a bill from the radiologist, from the anesthesiologist, from the hospital. They need to know, they want to know and understand what's the total cost going to be for me to get a knee replacement. And if I go to this particular facility, what's the average going to be at this particular facility versus if I go somewhere else?
So I'm just trying to understand how that would help somebody, because isn't it really based on their insurance coverage? I mean, it tells them what the average, what the cost is going to be, but what really is going to tell them what they're going to pay is related to their insurance coverage.
Yeah, so that's part of the challenge with the consumer data is, so with them having more and more higher levels of deductibles, or with HSAs, the fact if they go to one facility, it's going to cost $1,500 for a particular procedure, and it still fits within their deductible. They go somewhere else, it's going to cost them $25,000. And they're going to pay their deductible, and then after they meet their deductible, they're going to go pay a 20% coinsurance. It just depends.
Whether the provider participates with their I mean, there's so many missing pieces for them
It's a
to be
start.
able to interpret this in a
start.
way that's meaningful to them.
Yeah, so one of the other things that we didn't go into within the site as well, they can go ahead and plug in their benefit. They can say, I'm with Aetna, and I have a deductible of X, and I have a 20% coinsurance, and it should cost me in total around Y. You know, so we have some little tools in there that help with that. But it's still, it's again, you're very, very right. That's one of the items that, you know, how do we address that without making it too complicated, but yet giving them some sense. Now, the other thing that I think is very important is the employers, because they're footing the bill. We truly believe that the way that healthcare is going to change is by getting employers engaged, and not just during that 2-month window when they're looking to basically roll over their, or basically negotiate a new benefit package. Okay. Just some pieces of example here. You know, this one, for example, is knee replacement. As you can see, the wide variation as far as the overall cost for knee replacement. I will note that those that are on this side are the smaller areas up in our mountain areas, up in the Northwest. I think everybody, or the northern part of the state, and I think some people may have seen the Blues analysis that went out, and they highlighted a number of cities or areas within the country, and that was one of them. So, and as you can see, there's only 2 of them, which is Mercy Regional and Northern Colorado, that have high patient complexity. So, you know, so that one kind of ties in with cost.
So are any of those like your classic academic, you know, hospitals?
Well, what we've got here is, for example, Northern Colorado is Banner Health. We do have UC, which is the Poudre Valley, you know, which is the blue, which is on the northern part of the state. I think that's Fort Collins area. That's the blue, but that's a UC hospital system. Because this is knee replacement, we have obviously Children's Hospital that's part of the UC system as well. I'll say this amongst friends, but a lot of the cost differentials are for the most part not associated with complexity. It's associated with location and supply and demand. Okay. Another one to look at is, for example, this is births. On the bottom end, you have the Pueblo, Southern Colorado, and you can see the 4 SLV, San Luis Valley, Parkview, Montrose, St. Mary's, Corwin. That's Pueblo, Southern Colorado. And guess what? They're all on the lower scale. Lower cost areas. And then, whereas on this end, all of them are those regional, mountain, Northern Colorado areas. So again, from a vaginal birth perspective, when you've got an actual double of cost between the low and the high, and you've got very specific markets when you're looking at one end of the spectrum versus the other.
Do these costs include post-operative complications or readmission or anything like that?
Okay, so these are median, so it basically, it throws out the highs and the lows. Okay, so it basically is median cost, but it includes total cost of care associated with that particular procedure. Okay. Future plans, so we're rolling out in June, knock on wood, basic outpatient services. There will be 7 outpatient procedures that will be added. Actually, around 2 months later, still within 2015, we'll be rolling out imaging center procedures. So that takes us from close to, I don't know the final number, but it's going to be somewhere between 750 and 900 facilities that do perform some level of imaging procedures. We'll have approximately 15 that will be rolling out. And then the latter part of this year, December, may roll into January, we're then going to be rolling out 5 practice-based procedures that will basically cover every single physician group that we have within the state, as long as they meet the minimum requirements for reporting as far as minimum number of procedures. Colorado Medical Society was very engaged with us on picking those 5, as well as what quality indicators are going to be reported alongside of them. So they know what's coming. Okay. So just keep going. Basically just talking a little bit regarding payment reform. So really the question here is, why are we doing this? And as you can see, there's a wide variation in pricing. We're looking for different models as to how to go ahead and look at it. You know, obviously there's a wide variation in quality and outcomes, and not necessarily that there's a correlation between price and quality. Employers are extremely frustrated on the data and the information that they're seeing, and really trying to help make a change and help drive change. There's a National Center of Excellence model, you know, the Walmart and the Lowe's. Employers are also willing to drive change, both nationally and specifically within Colorado. We have a particular very large self-funded group called PARA, and they have 90,000 beneficiaries within Colorado. They have set up 5 centers of excellence within the state. And for those of their beneficiaries or members that participate or go to these centers of excellence, and again, it's the big ticket items. They're the large ticket items of knees and hip replacements and so on. They will waive the deductibles. They will waive the co-insurance. They will pay for you to stay in a hotel if it's beyond a certain number of miles. And people are doing it. And the cost variation is big. And it's not just those that are going from the north down to the south, or those that are in Grand Junction that were on the high end of the scale as far as payments. There's even a difference between 1 mile to an X, you know, of an average cost of $10,000 for one and $20,000 a mile down the street. So again, they're taking a stance, and a lot more of the large employers are looking to do the same. Some of the goals, and you know, I really won't go to go through all of this. You can read it, but I think the challenge really for us is the so what. You know, how can we bring parties together and really and have it so that it's mutually beneficial? And this is whether you're talking consumer, whether you're talking employer, whether you're talking payer in conjunction with the provider group, or some particular entity that may be part of a hospital system, then also trying to negotiate their contracts. We're doing some great initiatives right now with the state Medicaid, of which Medicaid represents 20% of the population right now and growing. And so, you know, right now they're looking at putting together episodes of care. We're creating bundles, and we're doing the analytics and developing the tools. We're starting with 12 procedural-based episodes. If anybody's heard of Prometheus, as a part of that, we also have PACs, which are potentially avoidable costs. And the information that we're getting out of this is amazing, and it varies, and it's by facility, it's billing practices, it's a number of different items. The plan is that they're going to do basically tiptoe, because again, they want it to be very progressive, but they want it to be well accepted. So we're going through a process of developing the analytics. We'll provide the reports. They'll go through a time period of at least a year of doing side-by-side analytics and reporting, fee-for-service versus what it would be under these particular PACs, or excuse me, episodes. And then there's a belief that there will be a natural push of costs that will go down, especially as there's benchmarking, comparative data to their peers, et cetera. And then the goal is after the year time frame that there will start to be discussions regarding, okay, how do we price these bundles, and then how do we go ahead and put those contracts in place. Okay, you know, the question really is that we keep asking all of the stakeholders and those we meet, how can we help? How can we help you? And really the key is comparative data, benchmarking, looking at benefit designs. You know, this is beyond just shifting cost to the consumer. You know, we cannot have payment reform actually without also implementing changes to care delivery. And we've got to be able to show this. Really some base knowledge is really total cost of care. You know, we're part of a national grant regarding the development of the algorithms and risk adjustments and some of the reporting and the dashboards associated with total cost of care. It's new stuff. I mean, everybody's heard about total cost of care, but reporting and creating these dashboards that are meaningful and actionable, it's new stuff. And so really there has to be a process of education, and we really need to be involved. And how do we help promote changing the delivery model in order to help put in some of this payment reform as well? You know, and you know, a lot of what's happening is the focus with the providers. There's so much information that they're receiving from all of the different payers. They're apples and oranges, they're not comparable. So they're very excited about being able to receive reports for their entire patient set that is meaningful, that they can understand, and then of course that they can start taking some action on. And that's all I have.
Oh, thanks. I'm going to ask you just a couple of questions, and we'll open it up to everybody else. So I wanted to just start really big. You know, for a state like New York that's still very early in trying to get its APD together, and we don't even have regulations in place yet. What are the key things that we have to get right the first time around? It'd be hard to undo versus things that could be incremental.
I'm a big believer that Big Bang Theory never really works, and that it's best to work through this incrementally, but the foundation has to be set up right. I mean, I believe that the regulations is really critical to helping to set the foundation, but still allow yourself the time to prioritize and implement gradually. One of the things that Civic basically had, and the state had put in a schedule, you know, regarding first they're going to bring in the large group, then they're going to move it to the small group, then they're going to be bringing in dental. And I think they missed the boat and didn't realize the issues that would come about by not incorporating to some level the self-funded. That's getting resolved now. There's a lot of support for that within the state. We're not anticipating, even though there's some issues nationally regarding the ERISA-based self-funded plans, but for the most part, we've got a lot of support, and I think that's because of the credibility already associated with with at least the Colorado's agency.
Did you have guidance in place in the beginning about data access such that actors other than the state would always be able to have this as an asset?
You know, again, this was before my time, but you know, my understanding is that there always was a belief, and it's a mandate that Civic has to become self-sustaining. So from that, there was always determined that there would be the ability to sell, you know, provide services associated and surrounding the data. So, you know, from that regard, I think there always was a belief that the information needed to be accessible, but the definition and the culture surrounding that, I think, was not necessarily there from the beginning, or the understanding of really what did that mean. So Civic started out very conservative in its approach of data release. From my perspective, that's a great place to start out. I would much rather to have come into the company starting from a very conservative approach than having one that was extremely loose and having to kind of corral it in. But we had to really come back and say the only way this information is going to be of value is to make it accessible within the framework, but again, as I said earlier, don't let it be your crutch. Let it just be your framework. I don't know if that answered your question.
Well, how important is...
David, can I ask a follow-up?
Yeah, go ahead.
Can you speak to what your self-sustainability model then looks like, since you indicated you were on track for 2016-17?
So we're on track. So initially, all of the work that was done was custom. And again, there was a lack of understanding of what information would be needed, what's the value to each of the various stakeholders, how would they use the information, et cetera. So there was really in the first year, because right now we're operating in the second year of data, non-public data release. So the first year of information, again, was all based on custom requests. And actually tied around data sets versus analytics. This year we've pretty much have now evolved to really understanding, okay, what are the needs? And I can tell you the needs are primarily, unless you're a heavy core research, it's not about personal health information. It's all de-identified data sets. It's really about information. So the privacy issues become more contained. So what we're doing now is really looking at, okay, what's the product portfolio in order to meet the needs of the various stakeholder groups, and that still has the framework of being in support of our mission, which is the AAA. And so we're really looking at, okay, how can we develop standardized type of reports that's lower cost but yet lower resource on our end? What are the types of subscriptions that we can go ahead and offer? It's also looking at where we're doing a lot of work with digital health companies, because again, it's about accessibility of the information as well. We also are working and talking with a number of the payer groups. So again, I don't know, answering your question, the product portfolio to truly reach increasing or sustainability and increasing value is evolving, but it's really going to have a fairly broad spectrum of uses, from the most complex and custom, to really from the physician practices. They just need information that makes sense and is usable for them. So we really got to look as to how to create standardized reports and information that's meaningful and low cost. Does that help, or does that answer your question?
Yeah, what happens in 2017 if the people haven't purchased the reports?
Well, they are now. They're doing it now, and the key for us is that we still participate in state grants, national grants. We still are involved in a lot of other types of services. Our goal initially to quote unquote, we're required to reach sustainability on the cost of the APCD, and we're pretty close to getting there now. The key for us is we want to also be able to support our overall mission, which includes all of the other activities that we do as well.
Thank you.
And we've got some great grant foundations within the state of Colorado that will help to ensure that we work through that transition.
We have great foundations in New York.
Great,
too.
yeah.
So let me ask you two questions about the consumer pricing side. I know this was in some ways just sort of a beta version that you put out there, but how have providers responded to that? The hospitals, the 4 procedures for the hospitals came out like 4 days before I started, so I got to experience some of the aftermath. Actually, it was all extremely positive because there were no surprises. So there was a significant number of meetings prior to the release regarding how it was going to be prepared, how it was going to be meaningful. There was a lot of meetings at the Colorado Hospital Association with every single board member of the Colorado Hospital Association that basically told Civic and the state, you can't do this. The information's not going to be meaningful and you're going to portray it wrong. So my predecessor as well as the team at Civic, really held firm in that, okay, so let's talk about how we're going to present the data. And the key above it all is it had to be consistent, it had to be accurate, it had to be credible, it had to be meaningful to the consumer, and some people were going to like it and others not so much. So this is what we ended up with, and there's pros and cons to compromises and agreements by committee. But the reality is we've got the buy-in of the facilities. They are in support of what we're doing. We've got the buy-in of the payers. For the most part, obviously the payers at any given time, have issues because they're the ones that are submitting the data and taking the brunt of the workload to get it sent to us. We're rolling out, as another example, the new data submission guides. We're having meetings with everyone from each of the payers. Their key APCD submitter gurus are there on the phone and providing input as well. What about the places that are at the high end of the spectrum? Are they feeling downward pressure on prices?
Well, before those particular hospitals that were on the high end of the cost, before it rolled out, because they all got to preview the data, they had special meetings regarding marketing communications, what they were going to respond to, how they were going to respond to the newspaper articles, etc. So yeah, they definitely, they definitely were engaged prior to the rollout, and they all received a lot of interviews, from the newspapers and others regarding why their costs were so high. As to how much it actually has changed their cost structures in the last year, only time will tell.
Okay, one more before I open it up. So obviously you have big plans to add a lot more to that consumer tool and new procedures and all. Like, what's the marketing plan to get more consumers to actually engage?
Yeah, so the reality is that Civic is never going to be a household name. I mean, we'd love for it to be. I think our team had originally thought it was going to be. But we really have to make sure that our information is a part of where the consumer is located and found where consumers go. So one place is that we've created widgets. We're basically have been working with the Colorado Business Group on health. You know, they have hundreds of employers that are a part of their network. We're working with other entities in order to get access to our site from where consumers go. We don't have the funding to basically go to Health or to WebMD and some of these other, you know, MSN sites and whatnot. We hope that at some point we can, but the reality is we need to go ahead and make our information accessible through others. We're also looking to where we can push this information out to have it be actually included in other applications. We're creating a mobile app, you know, for the information as well, and going to try to blast it out, you know, so that will be coming later this year as well. You know, so again, it's really about reach. Where is the consumer reach, and how can we touch as many as possible?
Anybody? Elizabeth, and I'll try to get all the way around. Just tell us who you are.
Hi, I'm Elizabeth Swain. I'm from the Community Healthcare Association, the Primary Care Association here in New York State. And I'm assuming that you're working with the Colorado folks and
Oh, yeah.
all those folks, yeah. So the AAA model, cost, quality, and patient engagement, patient experience. And we talked a little bit about consumer involvement. In New York State, we have 6 million people who are, you know, enrolled in various forms of the Medicaid program, and a big part of what we have to look at when we look at AAA stuff is patient experience, not just for the Medicaid patients, obviously, but that's a huge number. So how are you, I mean, you talked a little bit about consumer involvement, and the quality consumer piece in New York is a huge, complex challenge if you're using this data set to make decisions about where the best care is being provided. So how do you handle the quality piece? I didn't hear you talk about the sort of quality measurement as, you know, when you look at cost. Where's the quality?
So as it relates to the consumer, we don't release any new cost factors without also including a quality indicator. So we have the same level of cost and quality indicators on our site. The issue that we run into is what's the correlation. So our Colorado Medical Society, with the 5 physician-based or practice-based procedures that are going to be rolling out at the end of this year, they picked 5 particular quality indicators that we could provide. You know, so the other key is, you know, there's a lot of quality indicators out there that nobody can produce. So quality is very important. The key right now, a lot of the focus is on cost, but we are firm in that we have a cost factor, our indicator, we're gonna have a quality indicator along with it.
So what
The
do you
key
use
is,
for knee surgery, like you showed the chart? What would you use for knee surgery?
you know what, I have to pull it to see
Yeah,
which one.
I was just asking the same question, Mark.
Yeah,
I was like, yeah, I mean, how would you have that by hospital? Would you?
Well, we utilize the,
collects that?
you know, the Colorado Hospital Association produces a scorecard, a quality scorecard, so we use their scorecard, which is a number of quality indicators on there. I'd have to look to see what's and the correlations are very tough. It's more, and then we also do risk adjustment, you know, so we also provide the risk factors and complication factors on there.
So just a quick follow-up on that quality question, because this is, you know, what we're seeing in New York nationally is that, you know, providers can go out, hospital providers, primary care providers can go out and get all these credentials and standards, PCMH level 3, meaningful use, and there's a lack of alignment between, you know, those credentials and quality. And of course, often folks use those credentials as a reason why they're more expensive. So I think the alignment issue is going to be key. You know, you're going to have to see real quality, not just the you know, the stars and.
But what's the definition of quality? Is my patient satisfied? Is that the quality indicator? Or is there some potential, is there a viable indicator that can be pulled? And right now, a lot of the quality indicators are associated around tests. You know, again, they're what can be measurable. And I think that's a lot of the challenges. We're rolling out total cost of care, again, focusing on the physician side. Total cost of care, which we're doing risk adjustments, you know, so we can actually apply indexes to compare the state level and benchmark against the state of, you know, what's the complexity of your patient compared to the state, to your county, to your particular service area, whatever it may be, and there's multiple levels that we're including. And then we also then apply risk adjustment and to the cost so that they can do that level of relevant comparison. You know, so again, it's a start. You know, it's part of the incremental. I think it's going to be evolutionary. You know, a lot of the data is included in the meaningful use indicators and some of the standards that's located within the EMRs, and they're not necessarily in the claims data or other data sources. So it's a big challenge. The 5 indicators that the physician group picked, it's a stretch in any regard to say they're correlating to the items, but again, I think the key is that it's a start.
And those come from a separate source, or are they in the claims data? Are you accessing a different database for those?
You know, in some cases, we have a mix. So we have quality indicators. Again, it's more about percent of, you know, achieved, you know. So we have a certain number that we can pull from the quality, and others are other data sources that are produced from other means.
So those are not claims data sources?
It's a mix between claims and not.
Greg, did you ever remember?
And some of it's self-reported.
So total cost of care, for me, drives back to who is managing that patient population or who has primary responsibility for them, which is marvelous information if you can get it. You obviously have a technical issue, the attribution question of these patients are attached to these physicians
it's an algorithm.
in order to be able to track them out.
Yep.
But to the extent that you can do that across all payers, it's an absolutely phenomenal outcome. Have you got ways that you're doing that
Yeah,
people are
absolutely. And
with?
we're one of 5. We're part of the Robert Wood Johnson Total Cost of Care Initiative. Great, another foundation. They focus on a national basis. There's 5 different states that are participating in that, Colorado being one of them, and we believe that we're going to be able to participate in the next phase 2. But they've come up with very specific algorithms in order to define patients associated with a particular practice in this case. And I think it's in the last 18 months they had to have had at least 2 visits to a particular primary care. And so this phase 1 is associated primarily with primary care. We have another group that we're doing on a national basis, or another that we're actually trying to come up with some correlation with specialty. You know, so anyway, so yeah, it is a big challenge. It's new stuff, but it's actually allows the opportunity to really look at all that is happening with their particular patients that they may only see once, and they have no insight to what may be occurring across, you know, in other locations, other doctors, other facilities, etc. It's a great start. It's a start. Again, everything's incremental.
Jay.
So just want to go back to the quality question again. To me, the issue would be the outcome. And I hear you talking about an episode of care. So for a knee replacement, will you be able to track, say, a readmission for that issue or an infection? Because, you know, to me, I would pay more if I had a better chance, likely chance of an outcome. And the other predictor that we've seen in New York is the volume of procedures. Is that available for the patient?
Yep, so we're available for the patient? Or
yeah, so if I were going to pick someone who's doing a knee surgery, you know, this hospital does 15,000,
yep.
This hospital does 100.
Yep. So actually, as a part of what we show on the public site, you know, we show the number of procedures as well as, you know, what the average cost is, et cetera, you know, across the board. And we do report readmission rates. And some of the analytics that we're doing right now is hospitals themselves know if somebody comes back into their hospital and is readmitted, but they don't have the insight as to whether or not they're getting readmitted elsewhere. So we're looking at it across the entire, all of the facilities. And then the other thing that's really interesting is now we're getting some analytic requests or some drilling down further is, you know, applying the socioeconomic factors on top of it. You know, so how does that fit into readmissions, you know, where
What's
they're getting
your
their
data source for the socioeconomic factors?
Yeah.
What's your data source?
The data source is actually coming from all of the payers. So we have Medicare, Medicaid, and 20 different payers right now that are submitting into the APC.
Neil?
So how do you differentiate in your total cost? So there's multiple things, but I think you said it includes the doctor's fees and the hospital
It
fees,
includes
right?
all costs.
Right, and so does, when you look at quality, the outcome includes both an institutional, an outcome that's attributable to the institution, to the staff, to the post-operative care, and an outcome that's attributable to a particular physician. So there could be 5 orthopedists in the hospital that have different outcomes. The New York State has tremendous data on cardiac outcomes, and there is tremendous variability even within the institutions in terms of quality, and even with providers practicing in different, the same provider doing surgery in different institutions. So is it possible for a consumer to differentiate between 5 different surgeons at the same hospital and their complication rates and their outcomes? Because you know, it's not just the hospital that matters. It's really, and then you have the same issue on the payment, because it's also how much of pay, you're not doing this on charges, you're doing it on payments. So the payments are as much related to the regional payers as it is related to what the hospital would normally charge, right?
So around 70% of our claims, and I think I might have mentioned this briefly regarding the Clean Claim Act and some of the other regulations within Colorado, but around 70% of the claims have the rendering physician. It's a required field, but because some of the systems only report billable, the billing entity, you don't necessarily get the actual physician, shall we say in this case, who actually performed the service. So right now, the data would be a challenge to get anything that's credible. So right now, we do everything at the practice level or at the billing entity level. So if it's a hospitalist, we wouldn't necessarily be able to provide that level, at least from the claims data, we wouldn't be able to provide that level of detail. And it would be challenging to have it be consistent and across the board, even within the various docs within a practice. If it's a sole practitioner, won't be a problem. But, I'm sorry.
Mark, I think you have your hand up, right?
Yeah, well, I have 2 questions, I guess, left after all this. One is you talked about speeding up the reporting before and the trade-offs you were making. I was wondering if you're getting at things like quality, why the emphasis on speed, and what are you giving up in order to get that speed? So that's one question. The other question is, are the institutional buyers of your reports or data, do you have a sense they're using this information for payment reform type, you know, quality issues, payment for quality issues, and how are they dealing with the attribution issues that people have been raising?
So let me first talk about the buyers. One of the processes that we have to go through is that we can only release reports and or data and or perform analysis on approved uses of the data. So they have to spell out very specifically what their use is going to be, and it has to be in support of the triple aim or health operations, et cetera, payment reform, care delivery, et cetera. Health operations itself can be very, very broad. So the buyers in and of themselves have to define that. So we go through that vetting process with them, that it has to be for rural uses that will benefit Coloradans. Well, and we have a particular payer that currently is utilizing the data in order to review they're looking to get into a new market. So it improves competition within the state, which is a good thing from a cost perspective, et cetera, and a buyer choice or a consumer choice perspective. You know, so they're actually taking the data and looking at it, instead of applying actuarial assumptions into a particular market, they now have cost data. And again, it's aggregated data so that they're not getting issues that we run into from an antitrust perspective, but they're getting data that they now can make meaningful analysis regarding what should be the appropriate pricing for that particular market. So again, it varies across the board, but it has to be very, very specific. It can't just say, give me the data and I'm going to play. We've had a few that says they just want to play, and we've said no. Regarding the speed, we still have a significant amount of editing. We still have to do the provider indexing. The key is where we enrich the data and go through a numerous number of processes that really fill in the blanks through very specific processing and other tools. That's where we're potentially going to have some issues, shall we say. But we're looking to say, do we keep doing that on a quarterly basis? And then maybe the monthly data flows. So the key is they need to have it more current. It really is an issue, especially when we're merging clinical and when they're needing to evaluate clinical and claims data together. It's a big issue for us right now. I don't know if that answered your question. I think I kind of skirted around it. But
Sort of. I mean, just go back to the first thing about, are people saying they're using it for payment for quality purposes, your data, when they're buying it? And do you have a sense of how they're dealing with attribution issues, like who's responsible?
I have to say, you don't necessarily get any saying that they need the data for a quality purpose. It's usually very specific regarding assessing costs, understanding cost drivers. Right now at this point, they're primarily associated with analyses around utilization and cost.
Yes.
So you had said that the bulk of the burden is on the payers to provide you with data?
The payers are required to provide the data fees.
Right, but so what I mean is that each payer will have their own claims database with its own proprietary formatting and potentially significant differences, even though they may contain 85 to 90% of the same information. Do you require a common format for data submitted to you?
So we have a data submission guide, and actually it's there's been a lot of meetings, and actually the payers have all said they really like the Colorado data submission guide, and if there is a standard, a lot of them are adopting our submission guide, or a lot of the other states are. So they have to submit in the format and with the required fields that are outlined in the data submission field. We do allow some waivers, depending on the type of organization, et cetera. Obviously, we have some staff modeled HMOs. Some of the fields would be a little bit challenging or are not able because of their models. But for the most part, they all comply.
Because it makes sense that, I mean, at least for payers that are national or service multiple regions, that for states like New York that are developing their own system, that they might as well use the same common data format so that the payer essentially doesn't have to reinvent the wheel to provide the same information.
Yep, and we heard that there's a national, it's a NADO concept, National Association of Healthcare Data. I'm saying it wrong title, short version is NADO. And a number of there was one whole day that was associated with APCDs, and there was a panel of Aetna, the Blues, WellPoint, Cigna was up there as well, and one other payer. But basically they said that one of their main drivers is they would like to have a standard. And then they also mentioned that they'd like the standard to be Colorado. So we'd be more than happy to share. In fact, I think our data submission guide is public. So.
And I don't know if this is something you know off the top of your head, but do you have a sense of ballpark what percentage of your data has to be imputed due to the missing nature of the data submitted?
No, I couldn't tell you that. When the files first come in, we run through 330 plus edits, and then they go through some initial scrubbing just to see if the files pass, and if they meet the parameters. And even on some of them, they have to have, where there's some level of waivers, they still have to have a certain percentage that meet the thresholds. And any given month, we have upwards of 50% of the files that fail. So the resubmission process is fairly lengthy, and it's not the same ones. We have certain ones that are the you know, they're fairly typical to be on the fail list, but it's amazing as to how one month it works and the next month there's an issue with the files.
Perhaps not surprising.
You know, again, it's claims data, you know, so that in and of itself is challenging.
Okay, did you have your hand up?
Do you have claims data related to long-term post-acute care services like nursing homes and home health care?
If they're insured and as a part of a health policy, I mean a normal health policy, then the answer is yes. If it's part of an ancillary insurance program, then the answer is no.
So Medicare and Medicaid data you have and long-term care insurance, or?
Again, we have the medical plan. So if it was billed and paid under a medical plan, then again we got it. But if it's again part of a standard or an ancillary standalone, then we won't at all. Right now it's just the medical, and we'll get dental, but medical, pharmacy, and dental soon.
So actually I have two questions, and if you cut me off after one, that's fine. But first one is just how were you able to, like, what enabled you to get the self-funded plan data? Can you tell us a little bit about that?
It's been a 2-year process. So I'm fortunate in that I started doing the pushing after hearing my team and everybody else and all of the stakeholders. So basically we put together a draft proposal that addressed some of the issues. So for example, any ASO or TPA that has less than 1,000, they don't have to submit, which is consistent with what we're doing on the risk side. We also included an opt-out provision for the ERISA-based plans in 2015 and 16 claims data. So again, you know, I got to knock on the wood because there still is.
But this was sort of your own sort of quasi-regulatory authority, or it was part
well, no, we have to work through
legislation or the, okay.
Yeah, so this is regulate. This is modifying the regulation. So because the legislation uses the word payer, healthcare payer, it in essence is all, the legislation did not need to be modified. The constraints were included in how the regulation was originally drafted. So the changes that we've put in place and have gone through the state departments basically included then the self-funded information with, again, these 2 other provisions associated.
David's letting me get
Part
ask
2.
my second, thank you, which is totally different. But can you talk a little bit about how you are monitoring or tracking or trying to evaluate the impact of the consumer-facing sort of pricing stuff? And I guess
I think it's too
a
early.
future plan,
I think
but I
it's
mean,
actually,
how are you thinking about how you'll assess whether or not it's having an impact? Because obviously it's a sort of a hot issue. There's a lot of consumer-facing different kinds of scorecards and things like that, and big question marks about whether or not in different contexts people pay attention to them. And I'm just curious, like how do you think about tracking that, or is your strategy really more oriented towards like corporate or other?
It's a good question. As you can see, I'm contemplating as to what the answer. I mean, initially it's all about reach. How many consumers can we reach? And then there will be certain indicators, you know, regarding clicks and, you know, how many sites are actually posting our data on there. You know, how many other applications can we flow the information? So really, initially, it's about education and public awareness.
Right.
And which those 2 items are tied to how many are we reaching. Obviously, we'll be looking at click-throughs, but we're also looking as to how we can push the data out onto other types of sites and have it be accessible elsewhere. The other thing, too, is we're going to be adding a lot more regarding blogs and user. I mean, we've got a few where we're getting notices in from consumers, you know, regarding their complaints regarding how much they were charged for their birth. You know, and they were in the hospital for 6 hours and they were charged $15,000. You know, and so and basically the comments are, I wish I had this information prior to having my second child. You know, so again, I think it's going to be hit or miss in the beginning. It'll be evolutionary, as a lot of this will, but for us primarily it'll be reach.
Robin, I think you're going to get the last one.
Okay,
And it's also in response to your question. So we're from Fair Health, and in response to your question regarding consumer attitudes and feedback, in addition, as Anna was saying, we study analytics, but we also embed on our website a survey directly, so it's like a real-time laboratory for consumers to give us feedback, and it's fascinating. I'm sure you're getting that through other means in terms of people emailing you and so forth, but it's incredible feedback you get in terms of how they're using it along the continuum. You know, so we're learning that they're using it before they access care, making a decision whether to stay in-network or out-of-network, using the data to populate appeals, reimbursement appeals, to say, I'm seeing this market snapshot, why is my level of reimbursement? Sometimes they'll share with you the files that they've submitted on appeal. You don't really want that, but it's been fascinating to have that actual feedback loop in real time to hear about how they're using it. So I think it's an evolutionary process. And
can I ask a question of Robin, sort of related to her? I mean, I know she had the last question, but
you have the last question.
Sorry, because I wonder. I mean, we were just having the same conversation here again. Like what I was saying is like, well, it seems like fair from the consumer's perspective. Fair Health that does a lot of what this does, and Mark was saying, well, no, because if you go to Dr. Y, you can see Dr. Z 2 doors down is doing it for so much more less, so it's so much more concrete. Do you think, Robin, that's right, that it would be so much more helpful for consumers to have this level of detail by provider named out, called out, in a way that your work is, which is so helpful to at least us, is so aggregated? Do you think this would?
Absolutely, and as Anna was saying, I think you have to start somewhere, right? And we had a specific mandate, and the mandate was to be able to evaluate what your possible out-of-pocket exposure could be if you're going out for a particular service. Now you could know if you're going to Dr. Y, if you see that in this little community, this is what you might expect for charges. You can negotiate with Dr. Y. You don't know Dr. Z necessarily is next door. We would love that. I think we've tested some provider sentiment in New York, and we, like Anna, really try to engage our stakeholders and not ambush them and not surprise them, and try to work collaboratively with them and educate the consumers all along, bringing them with us. If there was some type of sort of state mandate or regulation or collective determination that that type of transparency, you know, there was a green light for that, we would be right there. We're moving incrementally to that. Obviously, it would be great to have wind at our back with some kind of regulation or support. I think they would be, you know, certainly advantaged by that. But from what we see already, what we're giving them, they're thanking us profusely for just peeling back the curtain and really empowering them to make a lot of decisions. And we couple it with a lot of educational information as well. So
you get the last word.
Well, you know, and tied to that, this is all about changing culture. I mean, consumer in general don't ask first how much it's going to cost them to go to the specialist. What they're used to now is that the doctor says, hey, you need to go see a specialist, and this is who I'm recommending you go to. So they go. They don't ask to say, well, how much does this cost? So I think the cultural changes that needs to occur is really about making this information more available in many different means and formats, because it's going to be testing. It's all going to be trial by error, and I don't even know if it's trial by error. It's just going to be a lot of testing in different avenues of different information that may be more effective. But it's got to get to the point of the consumer, and myself included, asking, how much is this going to cost me? And oh, by the way, is their quality any different than this other doctor who's charging $1,000 less? And so I think everybody, especially us, are wide open to what sort of tools, and we're hoping that these focus groups will really help with identifying what are some different and better ways to go ahead and get the information out that truly will change behavior, and let people know it's okay to ask. It's okay to find out what it's going to cost beforehand. Now, obviously non-emergent, but.
Well, we're out of time now, so I want to thank all of you for coming, particularly thank Anna for coming and sharing.